Welcome, everyone, and thank you for joining us today for the Tobacco Control Policy and Health Equity webinar. My name is Vanessa Torres, and I will be your WebEx technical support host. Before we dive into today's meeting, I wanted to provide some quick information on the webinar platform. All lines have been muted on entry and will remain muted for the duration of the webinar. Please submit questions throughout the presentation using the chat box and select all panelists. A moderator will ask the comments and/or questions on your behalf at the end of the presentation. If you require technical assistance, please feel free to contact me, the host, via the chat panel, and I'll be happy to assist you. If you need closed captioning, please refer to the link in the chat panel. We also wanted to make you aware that today's webinar is being recorded. This recording will be posted in the near future. And now I'd like to turn it over to April O to introduce our speaker.
Thanks so much, Vanessa. Hi, everyone, and thank you for joining this webinar. Next slide, please. So today we have a great panel for you today to go over this funding announcement on tobacco control policies to promote health equity. During our time together, we will be sharing a background around this funding announcement, some details about the funding opportunity announcement, as well as some resources, and there will be an opportunity for a Q&A with our panelists. I'd like to introduce our panelists that are here today. We have Dr. Bob Wallinger, who is a program officer in the Tobacco Control Research Branch at the National Cancer Institute. We also have Mary Garcia Casarin, who is a scientific officer with the Tobacco Regulatory Science Program at the NIH Office of Disease Prevention. We also have Priska Majuru, who's a program officer at the National Institute on Minority Health and Health Disparities, who will be with us on this panel as well. So with that, I'd like to toss it over to Bob Wallinger to give our background.
Good afternoon, everybody. So first of all, let me welcome you to the webinar this afternoon and to thank you for joining us. Hope everybody's having a great afternoon, or afternoon for those of you on the East Coast, and a good morning to those of you on the West Coast. So thanks for being with us today. Basically, I just wanted to give you some context for our Tobacco Control Research Branch as part of the Behavioral Research Program within the National Cancer Institute's Division of Cancer Control and Population Sciences. So you just see where we are located organizationally. TCRB, the Tobacco Control Research Branch, is the largest branch within the Behavioral Research Program, covering a pretty broad range of tobacco control research. And you'll see the website there for more information about BRP. So just wanted to jump into how we fund grants at NCI and NIH, and just to, I'm sure many of you are familiar with this, so I won't spend a lot of time, but just wanted to call your attention to a couple things. Of course, you're familiar with requests for applications, which is one type of way that we do it. And then also, more recently, we've been using NOCIs, Notices of Special Interest, which is basically a standard format that NIH uses to share research priorities. But this afternoon, we're focusing on program announcements with review, PARs. And the most important thing here is just to note that these types of applications get special review. We want to be sure that they are assigned to reviewers that have expertise in tobacco control policy research and who also understand the importance of community engagement and community-based participatory research. And we want to be sure, given the focus of this FOA, that we have people with experience in dissemination and implementation science. So by having a special review panel, we're able to ensure that we have that right expertise among the reviewer group. So again, pretty basic information here for any of you who've applied to NIH before, but the two mechanisms that we're using for this opportunity are the R01 and the R21. And the main thing to know here is that R01s are for larger grants. It's the most common funding mechanism used across all of NIH for larger grants that are 3 to 5 years long. And then the R21 is typically an exploratory or developmental grant It allows a limits up to 2 years of funding with a maximum of $275,000 of direct costs for the budget period. So again, it's really a question of scope of what your plan is. So these are the announcements. Hopefully you already found them by now and have checked them out on the web. You see that they were released on September 4th, so about 3 months ago. And the first one is for the R01, and the second one is the R21. They're very similar to one another, but just have the different conditions for each of those funding mechanisms. And then the third link there is just to link specifically to mention that NIMHD is also participating specifically in the R01 mechanism. And Prisca will talk more about that a little bit later. So just wanted to focus on the goal of the funding announcement, right? That's the important thing here. And the purpose of this opportunity is to support observational or intervention research to reduce health disparities in tobacco use and secondhand smoke in the U.S. and to promote health equity through scientific inquiry that's focused on innovative tobacco prevention and control policies. The long-term goal of this initiative is to reduce tobacco-related healthcare disparities, and in doing so, to promote health equity among all populations. And I can't emphasize that enough. That's clearly the intention of this and what we're trying to do with this type of research. And so specifically, the goals of the FOA are to understand how to improve the effectiveness of existing tobacco prevention and control policy strategies that would promote health equity, but also to look at new policy approaches that may not have been used before to promote health equity. So a couple of key definitions here I want to share with you at the outset. I think that many of you may be familiar with these, but just want to be explicit in calling your attention to these terms because they're used frequently in the field these days. So health disparities are a particular type of health difference that's closely linked with social or economic disadvantage. These disparities adversely affect groups of people who have systematically experienced greater social or economic obstacles to health based on their racial or ethnic groups, their religion, their socioeconomic status, gender, mental health, cognitive or sensory physical disabilities, their sexual orientation, where they live, or other characteristics that might be linked to discrimination or inclusion. So that's health disparities. And then the other term is health equity, which is the attainment of the highest health for all people. All people. Achieving health equity requires valuing everyone equally with focused and ongoing societal efforts to address avoidable inequalities, historical and contemporary injustices, and the elimination of health disparities. I'll mention quickly that one of our most recent NCI monograph 22, focuses specifically on these topics. It's called the Socio-Ecological Approach to Addressing Tobacco-Related Health Disparities, and you'll see a link to that in the FOA itself, to that monograph. But I highly commend that document to you. It's a great resource. And then this next definition is about social determinants of health. This is a term that we've heard used a lot recently, but I think that sometimes there's a little bit of confusion about exactly what it means. So here, social determinants are mostly responsible for health inequities. The unfair and unavoidable factors in health status that are seen within and between countries or sub-countries. So social determinants can be understood as the conditions in which people were born, grow, live, work, and age, including the health system. And these circumstances are shaped by the distribution of money, power, and resources at either the global, national, or local levels, which are, of course, themselves influenced by policy choices. And the important thing to note is that these factors are avoidable. They can be addressed through a complement of scientific activities that will reduce the burden of these factors and improve overall health. And here I'll just give a quick plug for a book that some of you may be familiar with called Just Medicine, A Cure for Racial Inequality in American Health. It was written by Dana Bowen Matthew. It was published in 2015, and she is now the Dean of the Law School at George Washington University here in D.C. But just a quick quote from this book that really captured my attention because I think it summarizes the context that we're talking about here. Says the book lays bare a disturbing contradiction. On one hand, injustice and inequality are anathema to our professed national identity. Yet on the other hand, unconscious bias has become an entrenched and acceptable social norm, empirically demonstrated to control decision makers not only in healthcare, but in civil and criminal justice proceedings, law enforcement, employment, media, and education. Unconscious racism has become the new normal. Therefore, she says, the great American tradition of running two separate but unequal medical systems for white and non-white patients is back. And so I think that kind of perspective and some of the things that she talks about in the book really outlines the context that we're operating in now. So want to focus on the populations that would be appropriate to use for putting your applications together. But I want to convey at the front that this is by no means an exhaustive list, but it's some of the populations that we think might be relevant. So, of course, racial or ethnic groups of people who are living in low-resource communities, certainly public housing residents, people who were exposed to secondhand smoke either at work or at home, and as well as lesbian, gay, bisexual, transgender, or queer populations, and then also people who are depressed or have comorbid psychiatric conditions or physical disabilities, and then also people who are patients within the system of federally qualified health centers. So these are all important populations that you might consider doing research on with. So here I just wanted to very quickly show you some of the disparities in some of these populations. And again, I think this is all stuff that many of you are very familiar with, but just wanted to provide a little bit of context here. So first of all is about smoking status among adults by poverty status over this time period. And here you just see that people who are in poverty, living below the poverty level, have significantly higher smoking rates consistently over this time period than people who are at the poverty level or for whom we don't know their status. No news here. And then also the issue of people with serious psychological distress. We know that mental health issues are very important, and this is just showing that anybody who has a serious mental health psychological distress has higher smoking rates than those without. And again, the issue of sexual orientation, so that we know people who are lesbian, gay, or bisexual have higher smoking rates than heterosexuals over this time period, and that's another important factor to consider. Here addresses the issue of secondhand smoke exposure, particularly among children aged 3 to 11 years. And so here you see that among those young children, at the earliest parts of their lives, that the rate of exposure for Black children is higher than either white or Mexican American populations. And so this is another exposure for these young children that would be appropriate to focus on. Here, this reflects the whole topic of T21, tobacco 21. I think many of you know that there was a rapid rise of states that were legislating on this topic, basically prohibiting the sale of tobacco products to anyone under the age of 21. And then at the end of last year, a federal law was passed to make this uniform across the U.S. We have a couple grants that are dealing with this topic already, but there certainly are variations in the states that might make this a topic to consider as well. So this slide basically is talking about cigarette use by receptivity to average anxiety.
Oh, Bob, I think we're losing you a little bit.
Whoops, yes?
Hi, Bob. Sorry, we're losing you a little bit with connectivity. It might be helpful if we turn off your camera and then we can continue. Sure. We lost you for the last few seconds.
Okay, great. So hopefully that'll be better now. Can you hear me?
Yes, sounds great.
Okay, thanks. I was just pointing out here on this slide that people with internalizing problems have a higher probability with low or moderate internalizing problems. So again, this would be another area of potential research. So this slide is interesting as well, and it shows about the inverse relationship that exists between the proportion of African Americans in a particular population versus the price of little cigars and cigarillos. So this is data from Washington, D.C., and on the left, you'll see the distribution of the African American population with the darker colors representing a higher quartile of African American populations in the city. And then on the right, you see the price per cigarillo across block groups. And basically, the darker colors here represent lower prices. So in those mostly African American neighborhoods, the price is lower for little cigars and cigarillos. So, this is so distressing to us. We've all lived through I could use a lot of expletives here, but the horrible year that 2020 has been on a lot of levels, and it kind of blew up when George Floyd was murdered in the end of May, and we've seen the direct result of racism. It really is an issue that the whole country's been grappling with, and now the coronavirus pandemic has exposed the intersection of racism and health disparities. So just really mention this because it's creating the context in which we're all operating right now. This is another article that I came across back in June because I do a lot of work on the whole topic of secondhand smoke and multi-unit housing. And this particular population in an article was talking about the fears of people who are living in low-income housing and how afraid they are about being exposed to COVID-19. And this is a particular problem with that population. Here's another article that just came out last week that some of you may have seen, but it's just highlighting that populations who are at higher risk for COVID-19, of course, include Black and brown people and those who are in certain job categories. So Blacks, Latinx, Alaska Natives, and American Indians are people who are more likely than whites to work in jobs that create their risk for increased risk for COVID-19 exposure and infection. And this was based on a report that was issued by the Urban Institute. But the trend could partially explain the racial health disparities that we're seeing during the pandemic. Since the beginning of the pandemic, workers in essential industries needing to work in person continued going to work and keeping the nation running while risking exposure to the coronavirus, the report says. And so I think that that's one of the factors that's contributing to this disparities that we're seeing. So I mentioned this whole topic of smoking in multi-unit housing. Any of you who've tracked this issue know, well, first of all, that HUD, the U.S. Department of Housing and Urban Development, passed a policy a couple years ago that make all public housing smoke-free, and that was a great advance. But frankly, that's a very specific segment of the housing market. Beyond that, there are places that have jurisdictions that have implemented comprehensive laws that say there's no smoking allowed in multi-unit housing, and these places so far have all been in California. And this is noted here because San Francisco just adopted a similar law, or no, excuse me, they have proposed a law and had the first vote on it last week. So these articles talk about that first vote. It will come up for a second vote in about a week. But if it does pass, and it's expected to, the first vote was 10-1, this would represent the largest city in the country. And I mention that just because what we know about policy change is that it happens by contagion, and it spreads. And so when it happens in one jurisdiction and is successfully implemented and has positive results, it begins to spread. And so my hope is that these kinds of policies will spread east across the country. So some of the potential research topics that you might consider for your applications. Here, are just a few examples. Certainly protecting non-smokers from secondhand smoke, demanding tobacco products through state or local pricing strategies, reducing the appeal of tobacco products through state or local restrictions on advertising and marketing, providing insurance coverage for tobacco dependence and treatment, and then other promising public and private policy approaches. So, the sky is the limit here, really, about things that you might consider. But when you're getting to the point of putting things together, you can certainly follow up and we can talk about your particular ideas. So here's, and I'll go quickly through these research questions, but here's a couple examples of questions. First of all, what communication strategies are most effective for promoting tobacco use prevention and cessation within the context of tobacco policy initiatives, and how can these messages be delivered or tailored to be censored to the local context and challenges with high-risk populations? And then next, what theoretical approaches might guide the development and testing of novel multi-unit interventions to reduce the use of tobacco products in high-risk populations? How do concurrent patterns of cannabis and tobacco use, considering their temporal ordering and contingent types of tobacco products, influence patterns of tobacco use within these high-risk populations? And how do state policy changes and variability in this legalization status affect tobacco use? And then finally, how health insurance tobacco cessation coverage, including Medicaid coverage, and policy influence access and utilization of evidence-based treatments by disparate populations. So quickly, this is about the design, analysis, and sample size considerations for policy studies. And I would just invite you to look at, potential designs here might be a parallel group or clustered randomized trial, step web group, or a cluster randomized trial, multiple baseline design, or other quasi-experimental designs. But the thing to note here is that website that's at the bottom of the page that will link you to a resource there that you might find very useful. And with that, I'll kick it over to Mary to talk about the PhenX Toolkit.
Everyone, again, my name is Mary Garcia, and I'm just going to turn off my video in case my internet starts acting up, so bear with me here. I represent the Office of Disease Prevention, also known as ODP, and I'm just here to give you an introduction to the PhenX Toolkit. Maybe this is a very familiar topic for some of you, but I just want to make sure that everybody gets a better understanding of this toolkit and how you can incorporate it into your research design. At our office, ODP, we don't manage grants, but instead what we do is we support and develop different tools that investigators can use for their specific research. The PhenX Toolkit is one of those tools, and we actually encourage investigators to use this toolkit in the applications. The slider I have right here is mainly for you to get familiar to the website, so I really encourage you to go into the website and get familiar with the different collections that are there. So this is a very, maybe you cannot see the whole thing, but it's a very small screenshot of the homepage of the PhenX Toolkit. And the PhenX, it's taken from the terms phenotypes and exposures. And this is mainly what we plan to do with this toolkit is these measures are meant to serve as common data elements in your studies, which provides a method to more effectively compare data or results across your studies or combine data or results. For example, in a meta-analysis. The measurement protocol in the PhenX Toolkit are available to all investigators, and they're very easy to download for your studies. As you can see from the homepage, the PhenX Toolkit has many of its measures organized into collections. 3 of those collections are very, very relevant to the topic today. These are the Substance Abuse and Addiction Collection, the Tobacco Regulatory Research Collection, and the Social Determinants of Health. One of a very important point here is that all these measures were actually identified by working groups that they met during many times to make sure that they have a reasonable number of measures. Another very important thing is that these are not meant to replace some very specific measures that you might have for your research design. These are meant to add to those measures. So by all means, don't replace the ones that you think are really important with some of these collections. Instead, we want you to incorporate some of these measures into your research design. Another thing is, once you become familiar with the website, if you have specific questions, you can contact me. If I don't know the answer, I will put you in touch with an expert in this toolkit. And we really encourage all investigators to get familiar with it and try to use some of these specific measures into your research design. With that, I think I am done with this slide. So I hand it back to Bob.
Great. Thanks very much, Mary. We'll just move on to Priska. Priska?
Can you hear me?
Yep.
Okay, thank you so much, Bob and Mary. So here I wanted to give you a quick summary on what NIMHD is about and what we found even in the context of this funding opportunity. The NIMHD mission is to lead scientific research to improve minority health and reduce health disparities in the U.S. populations. Our research focuses on population groups that include African Americans, Hispanics, Native Americans, Asian Americans, and Pacific Highlanders. We also focus on rural populations, immigrants, and other population groups such as sexual gender minorities. These groups, like Bob mentioned before, are more exposed to tobacco exposure, whether it's primary exposure or secondary exposures. NIMHD aims to raise awareness on the prevalence and impact of health disparities and disseminate effective individual, community, and population-level interventions to reduce health disparities in the populations that we serve. Our current research priorities include doing research in basic science research, population, community-based participatory research, and clinical and health services research. So, next slide, Bob. For this funding opportunity, we are interested in population and community-based research and clinical and health services research. We are interested only in R01 applications like you saw in the notice that we published. So we are not going to fund in any R21 applications. The research could target any of the aforementioned population groups. You could target any age groups, and you could also address behavior and modality use of tobacco. You could address access to the different types of tobacco products. Studies that enhance recruitment and retention of minority and health disparity populations are more important for your application to be considered responsive to the NIMHD mission. We encourage applicants to consider multi-level studies, and you can find the research framework on our website, and we've put a link here. You can also contact any of our NIMHD program officials for guidance on the research framework. And I'll be happy to answer your questions during this process before submission of your applications. And I'll be happy to take your questions if you present them in the chat. Thank you very much. Back to you,
Great.
Bob.
Thanks very much, Priska and Mary. Appreciate that. So next, we're going to focus on dissemination and implementation science and how that fits in with this FOA. And I just wanted to take the opportunity to bring this to your attention. It's an important part of this FOA. And I asked April to be part of our panel today because she's one of our experts on this topic in our division at NCI. And so when we get to the Q&A, she can help out with this as well. But basically, the point here is that we know dissemination and implementation of research are enhanced when needs, perspectives, and goals of the end users are factored in from the beginning. So that we really want to encourage all of you to keep to think about that from the very outset. All the applications must include an overall strategy that builds upon rigorous dissemination and implementation science. So here, the research strategy you'll see this language in the FOA itself. Does the overall strategy employ innovative approaches that build upon rigorous dissemination and implementation science? And then in your approach, investigators should include a well-designed plan for proactively disseminating and implementing research findings that include, first, a specific plan for identifying and engaging critical community partners in the research. Second, clearly described roles and responsibilities of key partners. And third, plans for regarding the nature and extent of future collaborations. And I just really want to highlight that because one of the things that's novel about this FOA is that these things are part of the scoring criteria for the review panel as they consider applications. And so I just want to emphasize that you really shouldn't gloss over that or not fully address it in designing your application. So we can talk more about that later if you want, but I just want to emphasize that point now. So the other thing, we've all are living through COVID, and it's upended a lot of things this year. We're all hopeful that we'll turn the corner very soon, but we thought it was important to include this language because we want to acknowledge that we understand the environment that the pandemic has had on broader health, social, cultural, and economic conditions, and how this might impact the adoption and implementation of tobacco control policies. Many of the populations who are most at risk for tobacco use and tobacco-related cancers are, of course, the same people who are disproportionately bearing the burden of the pandemic that we're living through. So applications can reflect the current conditions and the interactions there, but it's also important, this notice that's listed here basically tries to articulate that it's not a condition, that basically that we're not going to allow contingency plans, or that reviewers will not factor in contingency plans. So you shouldn't write into your application, we're going to do this because of these circumstances or whatever, but assume that the temporary and complications related to COVID-19 should not affect your scores. So I know that's a bit of a concern. We're happy to talk with you about that offline afterwards if you want, and I can put you in touch with the scientific review officers as well. They will be explaining that to reviewers as we get to that point of the process. So just want to be sure that everyone reads the FOAs very carefully. The details are all there in black and white. We've already had one submission date, but the thing to note here is that we're using standard review dates, and those are linked in the FOA themselves. They're a little bit different for the R01 and the R21, but very similar. But just check those out and follow those details depending on which type of application you want to use. And then also just to remind those of you who've not been through this process before, we really appreciate it if you submit a short letter of intent about 30 days prior to the date you're going to submit your application. Now, of course, these are not required, but what this does is it allows me to gather all this information and pass it on to the SRO who's managing the review so that she will have a better handle on the types of applications that are coming in, and therefore what types of reviewers or what types of expertise from reviewers she should be trying to recruit. So I just invite you to do that. It will help you in the long run. Again, start dates are there. The expiration, this is good for 3 years, basically. And to give yourself ample time, if you're not already registered in these systems, I don't need to tell any of you these days that IT problems are the bane of our existence, right? And that when things can go wrong, they will. So just give yourself plenty of time to get registered on all these systems and ask and get answered whatever questions you may have. So here's some other important information. I don't think any of this is a big surprise to any of you, but basically, that the reviewers will have the right expertise and also have background and experience with health disparities and tobacco control, the period of the time for the two different mechanisms, that foreign and non-domestic applications are not eligible. The intention of this FOA is to focus on U.S. policies and populations here in the U.S. I've seen some questions come up about this, and I'm happy to address those in the Q&A period, or if it pertains to your specific situation, we can have a follow-up conversation offline, and I'm happy to do that with folks. Of course, I don't do biology, and so biological mechanisms would not be appropriate for this. And then if you're doing a large application with direct costs over $500,000 in any year, there's a separate process you have to go through to get an ARA approved in advance, and you want to be sure to leave at least 8 weeks or longer to go through that process. So again, we can talk to you separately about that. And then there's a link to applications that deal specifically with economics. Can't even say the word, but more information there if you want to consult that. So we're available to answer questions that folks may have. April will moderate for us and try to steer the questions towards whomever's the most appropriate person. So April, we'll let you take it away. Thanks.
Okay, great. Thanks, Bob, Priska, and Mary for the great background and introduction to this funding announcement. So I'd like to invite folks to put within the chat, you'll see that on hopefully the lower right-hand corner, there's like 3 little dots, and you can click on more options and then click on chat if you're not able to see it in your window. And so please put in your questions into the chat. So while you're thinking of questions, we did have one question that was in the chat, and I guess I'll summarize this question, although, Bob, I think you might have answered it already in your prior slide. Is the research that's proposed, is it required to be exclusively done in the USA? And should the primary applicant be from the US? Can other collaborators be from low and middle income countries or LMICs? And so, yeah, Bob, would you like to take that?
Yeah, sure. I'll try. And so I first would say that, yes, collaborators from outside the U.S. are certainly appropriate if they have the right type of expertise. But again, the intention here is research that would be conducted within the U.S. And again, the ultimate audience for this research is the people who are managing state and local tobacco control programs on the front lines. And we want to provide them with the latest and best evidence base upon which to make decisions for their programs. So we certainly know, and I manage large grants that are around the world, and we know that lots of great work is being done around the world. But for the purpose of this FOA, we really want to focus on research that's being conducted here in the U.S. because it is policy specific, and it's contingent, therefore, on the policy environment here in the U.S. So.
Great. Thank you very much, Bob. And we have other questions that are coming through chat. The next question, and I think this would be for all panelists, maybe you can talk a little bit about interest within your office or IC. What is the level of interest around ENDS or electronic nicotine delivery systems for this specific PAR? Thank you. And maybe we'll start with Bob, since you've just finished up, and then we'll go to Mary and Priska.
Yes, and I definitely would want Mary to chime in here. Her office is helping with our intersection with FDA on things related to this, as well as other NIH components. But so what I would say about this is that certainly we're all aware that ENDS use is going up significantly. Policies related to ENDS would be responsive to this FOA, and so we certainly could consider them. And what distinguishes this FOA is the focus on promoting health equity, right? So there has to be a very clear intersection of the research questions and how they would impact a particular population so that it may contribute to promoting health equity. And then the other component that's important is, as I was mentioning before, the whole idea that there really is a strong community engagement focus. And so if you have a design that is appropriately including community partners, and that you're kind of focusing your application on that would be appropriate. But I also, and it's come up just recently with other people who are submitting on this, There are other FOAs that are specifically dealing with ENDS research. My colleague Rachel Grana-Main is the point person on one of those. Some of you may be aware of those or maybe even submitted to one of those announcements, but that's certainly appropriate. And so depending on your specific aims and the populations you're dealing with would probably determine which is a more appropriate announcement to respond to. But again, I think those are specific questions that we should probably deal with them on a case-by-case basis.
Mary Garcia from ODP. So yes, and I also would encourage everyone to, as Bob said, it's very important to look at your specific aims. I think that will be determine what is the most appropriate RFA for you. But I also invite you to take a look at the Tobacco Regulatory Science Program website that is hosted in the Office of Disease Prevention. I think you can see what RFAs are active there and whether your research fits whether these RFA or another ones. And feel free to contact us by email. We can take a look at your research and your overall research and help you determine what is a better RFA for your specific study.
Thank you, Mary. Go ahead, Priska.
Yeah, NIMHD is interested in ENDS, and so you could submit applications that address that. Basically, we're looking at all the products of tobacco. And you can also visit our website to see the trans-NIH ENDS FOAs. But for this particular funding opportunity, yes, we are interested in that, in the ENDS.
Great, thank you all. So we have another question related to scope within the PAR. The other question is around, is there interest in secondary data analysis of existing data sets, or is this something where primary data collection is preferred for this PAR? I will do the same, asking for each IC and office.
So I guess I would say that depending on the circumstances, that it's possible, for an R21 that secondary data analysis would be responsive. So again, we can follow up and talk about your particular case, but it probably would be. But I would think that it would best fit with an R21 rather than an R01.
Great.
I'm sorry to sound like a broken record, but we do have in R21 that is a secondary data analysis R21 under the Tobacco Regulatory Science Program. But again, this is all depend on your research questions. And so this is a conversation that we can continue after the webinar as well. You can email us and ask some specific questions about it.
Fantastic. Great. Go ahead.
NIMHD, it all depends on the data that you're going to analyze, of course, looking at the statistical analysis and sample size and all those things, and the question and the aims. So it's probably feasible. We're not participating on the R21, so just remembering that we only take R01s.
Great. Thank you for that reminder, Priska. And thank you all for responding. Another scope-related question for this specific PAR. A question is, are policies that are under FDA regulatory authority deemed relevant for this specific PAR, for example, warning labels, or is this really a focus on state policies?
So that's a good question. So yes, I think warning labels are a topic that could be responsive. I mentioned just the whole idea about advertising and marketing as well. So those are other things that that would fit. But again, if it's something that we know that FDA is interested in funding themselves, you may be better off looking at some of the FDA specific announcements that are out there. I noticed a couple FDA colleagues in the group, and if any of them want to jump in, we'd be happy to hear from them. But if not, feel free to follow up with us afterwards, and we can help steer that. And again, that's the role that Mary and
Yeah, we can follow up on that. I have no comments.
Okay, great. So Bob, we just lost you for just a few seconds at the tail end, but Mary said that questions could be forwarded to her about that FDA question as well, depending on the scope and what's being proposed. Is that right, Mary?
Yes, that is correct.
Okay, great. All right, we have another question, and this is kind of related to scope and a little bit around grantsmanship. So in the past, what the question is in the past, proposal that has been focused on working with Latino immigrants in Southern Florida has been criticized for focusing only within a specific geographic area. Despite the high need for interventions with this particular population and in this geographic area. Is the grantee going to be penalized for proposing research that focuses on Southern Florida? Or for that matter, making it more broad, any specific geographic region?
So I'm happy to try to take a stab at this with the caveat that I say all the time, and any of you that have talked with me about this have do, right? But so from
sorry, Bob, I'm sorry, Bob, to interrupt. We lost you for just a second. Do you mind starting again?
Yeah, sorry about that.
Sorry.
What I was just saying is that I'm happy to respond to this, but just emphasize the feedback that I give to any applicant when I'm talking to them is that I never like to anticipate what a study section is going to say or do, right? So that's the major caveat for anything I would say here. But again, given what I was saying earlier about the interest in informing policies that would apply or help guide decisions in state-level tobacco control programs, that I think that assuming that you can get the right sample size to have adequate power for the study, then yeah, I think it would be appropriate to look at a particular population like that. We have another grant that's looking at secondhand smoke policies in several states, so it's broader than just one, but it's looking at a region of the country. And again, if you can make a case for why you think that that's important and that there's not enough information known about a particular population or how a policy would affect a particular population, then we're happy to include that.
Great. Another question related to scope. We'll go through the scope questions first. Are interventions to make flavoring or menthol bans more effective in line with this program? Or is it more looking at effects of flavoring bans on equity that's more appropriate for this specific PAR?
I'm sorry.
Sure. So this could go to any of the panelists. So within the scope of this PAR, are interventions to make flavoring bans more effective within scope of this PAR, or is the PAR seeking research questions aimed at looking at the effects of flavoring bans in advancing equity?
Well, policies regarding flavor bans would certainly be responsible. We know that that's a major topic coming up in different jurisdictions. So I think I would punt this to a follow-up conversation with whoever's asking it about your specific design and how you would be trying to frame the questions. But, the broad topic is certainly responsive.
Yeah, that's great, Bob. And I'll pause in case Mary or Priska have anything to add to that.
No, I don't have any further comments. Thank you.
Great. And, you know, with some of these questions, too, about some of your specific research questions you may have, I do encourage you, as Bob shared earlier in the webinar, to put together a specific aims page that includes your research questions and really a highlight of the research methods you plan within your proposal to answer that question, and share them with a program officer so you can get feedback. So the other question is, one of the disparities populations, or populations experiencing disparities or identified as experiencing disparities, are those rural populations. So is rurality included in definitions and within scope of this PAR?
Yes, I think certainly rural populations, you know, when I mentioned geographic issues, that would certainly be one way that, you know, you could frame an application.
Right. Okay. And then also, would it be of interest for this PAR to include settings such as schools and colleges?
I'm sorry, what about schools and colleges?
Would it be within scope to include for proposals that are within schools or college settings?
Yeah, if there are policies that we're dealing with people in schools, yeah, I think so.
Great. One more question related to scope. Does research on social media and or digital technology fit into tobacco control policies? It is possible, for example, that a statewide policy could be in place on digital cessation similar to Quitline. Does that fall under policy, or is that viewed as clinical cessation? And I'll just add a little comment here. Bob, Mary, and Priska, I think this question may be related to how policies are conceptualized for this PAR, whether it's big P policy and law, or is it sort of organizational policies or small p?
I need to think about that a little bit, to be honest. Again, it would depend a little bit on the specific circumstances, but organizational policies would certainly be, and if I guess I want to talk to the person about how and what individual policies they might be thinking about, but.
Great.
Yeah,
thank you.
Also, this would need a follow-up, but as we are seeing more and more studies getting data from social media, it all depends on the question and what population we're targeting, or the PI is targeting as well.
Great. And I'll just also add that NCI does have a PAR that includes and within scope is examining digital interventions as well as social media interventions. So that might be another PAR to consider for that one as well. But again, encourage you to put together an aims page and share that with any of the program officers here on the line to get a sense of potential next steps. All right, so questions continue to come in, and this is taking a bit of a shift. Bob, there's a question, if you don't mind repeating what you were saying about COVID contingency plans, please. I believe that was the 34th slide in our slide deck. This is it. Great, thanks. So if you're on mute, can't hear you.
Sorry, I was trying to switch over to the phone line, hoping that might work better. But anyway, so what I was trying to say was that the environment that we're living in, you know, is appropriate, and that it makes sense to address that, but that the distinction is that reviewers will not consider contingency plans. So we don't want you to submit an application that says we're going to do this under these circumstances and that under other circumstances, whatever. We want you to submit the best science, And of course, what I was trying to get at was that in this context, for instance, local health departments may be prioritizing responses to COVID above, policies that might be very important for tobacco control, but because of the circumstances, their attention may be, maybe not focused on this. And so just acknowledging the reality of the environment we're in, but not wanting that to influence your plans too much.
Great, thank you. Thank you very much. So the next question is, are postdocs eligible to apply for the R21 mechanism?
I'm not aware of anything that would say they're not. April, you may know more about that as well, but that's, I think anybody's eligible. And the challenge, of course, is that you get to go up against peer reviewers, right, who will weigh your range of experience in making assessments about things. But certainly, if you've got the right expertise and interest, I would encourage everybody to apply. And as some of the people here on this call know, this is a long process, and you have to go through several different iterations before you get a hit. So nothing wrong with starting sooner rather than later.
That's great advice, Bob, and I would agree with that. And I would also just suggest that you work with some mentors at your institution or even outside of your institution as you start to frame your specific aims. Do contact a program officer to talk to them about sort of scope within the R21, talk to them to get feedback on your aims. And sometimes different postdocs are paid under sort of different training mechanisms, so it is worthwhile talking to the program officer if you are under a specific training mechanism about that, your status, and then look at that R21. So thank you for that question. We have 3 minutes left in the webinar, and one of our last questions, and this one I think might be somewhat straightforward to respond to. For all the panelists, do you have in mind the specific number of grants you'd like to fund through this funding announcement?
So I'll jump in first and would be glad to hear from my colleagues. I would say that no, we don't have a specific number of grants. The whole thing is contingent upon the review process and what the scores are, so that any of you who score well enough to get past our pay line are welcome to come to the table. It's not as if there's that's one of the things about this PIR mechanism. There's not a specific amount of money that's set aside as if it were not RFA, there's a designated amount of money, right? And we only can fund until we get to that, until we spend that money. But with the PAR, anybody that gets over the hurdle of our pay line is probably going to be funded.
Any other comment related to that from Mary or Priska? Anything to add?
Since this is a PAR, it's all going to depend on how well your application does in peer review. And NIMHD does not have a pay line per se, but it's going to be meritorious from the review process. And also, of course, I should mention that we do not fund any applications that have a direct cost of over 500 Ks. So if you were planning to request that from us, we won't be able to honor it.
Great. Thank you, Priska. One last question, I'm sorry, but this one I think I'm going to make a referral. The question was, what is the correlation of high rates of smokers in African Americans and their low income status? Bob Bollinger did refer early in his background remarks to the Tobacco Monograph series, so that is available on the NCI website. So I do encourage folks to check out that monograph series to get some of that information. And also at NCI, there is the SEER database that could also be really helpful to take a look at as well. So with that, I believe there's one last slide that lists some resources. So I was wondering if we could just have that up as we close. Yeah, so thank you so much for participating in this webinar. You're welcome to check out these sites here. Follow us on Twitter, and the Q&A will be posted on the webinar on our website. Bob, is there any final remarks that you'd like to share to close us out?
Well, just thank everybody for joining today. We hope that you found the information useful. And again, if you have specific questions about applications you're going to put together, feel free to follow up with any of the three of us, and we'll be happy to try to field those. So thanks very much for participating, and for my colleagues for joining us today.
Great. Thank you, everyone. Have a great afternoon, and thank you for your interest in this funding announcement.